Talk today is cardiorenal syndrome. Is the association real? It would have been far more easier for me to just say yes and walk out of here with all the laptop troubles. But since the slides are on, I might as well just proceed and show you why I feel that way. What is cardiorenal syndrome in the first place? What are the types of cardiorenal syndromes? And my answer is yes, there is an association. And I would like to use pathophysiological basis, show some links in biomarkers, show the link between these two organs epidemiologically and how they interact in the treatment of patients, and then try to conclude my talk with those thoughts. Is it actually cardiorenal or renocardiac? Very unclear. The definition is very simple. Pathophysiological disorder of the heart and kidneys, whereby acute or chronic dysfunction in one organ induces acute or chronic dysfunction in the other. So it doesn't have to be cardiorenal all the time. It can be renocardiac otherwise. It's just one organ dysfunction leading to the other organ dysfunction over a period of time, either acutely or chronically. What are the various types? This again goes back to the previous definition. If you think of it, it's kind of intuitive. And recently, Dr. Ronco and colleagues have just come up with this kind of a classification to probably simplify this whole issue, so we can kind of categorize it and understand it slightly better and know what the implications are. Type 1 is acute cardiorenal syndrome, where acute dysfunction of the heart, as in a case of myocardial infarction and cardiogenic shock, causing acute kidney injury. Type 2, chronic cardiorenal syndrome, where patients who have chronic heart failure over time develop progressive worsening renal dysfunction that ultimately ends up in end-stage renal disease and affects their outcome. Type 3 is acute renocardiac, where the primary problem happens in the kidney. Something acutely happens to the kidney. For example, glomerulonephritis, that subsequently causes either fluid overload, arrhythmias because of electrolyte imbalances and acidosis, coagulopathy causing pericardial effusion or tamponade, or any kind of cardiac dysfunction that is associated with the acute renal dysfunction. Type 4, chronic renocardiac syndromes, where chronic renal failure increases the cardiovascular mortality of these patients, either from atherosclerosis or from non-atherosclerotic mechanisms. And type 5 is a systemic problem that simultaneously affects both the heart and kidney. For example, sepsis clearly affects both the heart and kidney in various ways. So this is how the classification has been done recently to make it more clear and lucid. And in each one of those, there are several mechanisms that make the heart and kidney interact with each other. I will go through the basic arguments of why I feel these two organs are strongly linked to each other. We'll start with the pathophysiological links. The commonest reason all of us would say is it has got to be the low cardiac output still. I mean, what other reason could be there for the kidneys to fail when the heart fails? No, it has got to be the low cardiac output. No blood flow to the kidney causing acute kidney injury. And clearly there is decreased renal blood flow in patients with cardiogenic shock or low cardiac output. There is decreased perfusion pressure that happens with blood pressure changes. And at least we have all seen in the ICU that when I start a little bit of dobutamine or whatever inotrope of your choice, it does marginally improve at least the urine output in the short term. I'm not talking about dopamine here for different reasons. It's purely inotropic drugs like dobutamine or adrenaline. Sometimes we do see transient improvements in renal function. So it makes very intuitive sense that it is the low cardiac output that probably leads to the acute kidney injury. However, this has been recently argued and said that there are much more to the acute cardiorenal syndrome than just low cardiac output. Low cardiac output, no doubt, is a contributing factor, but there are many more other factors that probably play an equally important role and are implicated both in the pathophysiology and then serve as treatment targets in acute cardiorenal syndromes. First of all, there are several studies. I've just quoted only one study, clearly saying that there is absolutely no correlation. People put PA catheters in patients, measured their cardiac output, and looked at the degree of renal dysfunction. Clearly no correlation between the hemodynamic status, the cardiac output, and the baseline renal function. Or if a specific hemodynamic was targeted and the patient's hemodynamic was optimized, that did not correlate with worsening renal dysfunction. So either the cardiac output in the first place did not correlate with the renal dysfunction, or if you try to improve the cardiac output, there was no proportionate improvements in renal function most of the time. And more interestingly, what they found was it is the baseline renal function that determined the prognosis, but not the degree of worsening of the renal function that determined the prognosis. It tells me two things. One, by merely improving cardiac output, I'm not going to be able to change significantly the outcome of the kidneys. And two, whatever kidney status I have originally impacts the outcome of the heart at baseline. So both are very clearly evident from this one particular study. And in one of the studies, clearly people showed that the degree of renal function has a much, much higher predictive value of poor prognosis than even NIHA class or any other routine things we would look for in heart failure patients. This is the study I was quoting to you about, where they've just put a PA catheter in, they've measured renal vascular resistance, filtration fraction, and GFR. And I just would like to point to the GFR graph on the right-hand corner, where the GFR doesn't drop significantly until your cardiac index goes less than 1.5. Between a range of 1.5 to 2, essentially the GFR doesn't change, and mild change happens when the cardiac index goes from 2 to less than 2. Again, clearly saying that unless the cardiac output is significantly low, we may not have much changes in kidney injuries, probably because of adaptive mechanisms and probably because there are also other reasons why kidney injury can happen. And cardiorenal syndrome is present in patients with preserved systolic function, patients who have diastolic dysfunction. If you look at all comers with cardiorenal syndrome, almost equal proportions are seen even in systolic and diastolic dysfunction. So the cardiac output alone cannot be the only factor determining acute kidney injury in these kinds of patients. So what else could be the problem? Forward flow is not the only problem. So people started looking at the back flow or stagnation of the blood that happens in the renal capillaries. And there is very good data that says that as the CVP progressively increases, CVP is a surrogate of right atrial pressure, and as the right atrial pressure keeps increasing, the black flow on the renal capillary side becomes very high, that minimizes the glomerular filtration, and you have progressive worsening and serum creatinine. Similarly, intra-abdominal pressure, as the intra-abdominal pressure keeps going up, people used to believe that it is the external pressure on the kidneys that compresses the renal veins, which is not considered to be the main mechanism of kidney injury in intra-abdominal hypertension. People believe it acts by the same mechanism, where there is more venous congestion on the renal venous capillary slide, then there is decrease in GFR over time. And people have clearly showed that as the IAP is decreased by diuresis or by opening the belly, clearly the GFR significantly improves when the pressure goes down. So clearly the back flow from the heart also seems to affect the acute kidney injury that happens in cardiorenal syndromes. And then our good old renin-angiotensin-aldosterone mechanism comes in. The font may not be very clear. In heart failure patients, there is definitely renal blood flow decrease, and because of that, there is renin-angiotensin-aldosterone activation. We all know it increases aldosterone sodium retention and increases the preload and puts more stretch on the atrium. Simultaneously, it also causes systemic sympathetic activation, causing vasoconstriction and increasing afterload. Both could be deleterious to a failing heart. But what people have recently found is actually angiotensin II activates NADPH oxidase. Because of this, there is a lot of free radical oxygen generation that in fact goes and causes more endothelial damage and vascular inflammation. In the long term, causes more atherosclerosis. Angiotensin also releases IL-6, TNF-alpha and growth factors that actually cause more and more fibrosis in every vessel that is there in the body, including the cardiac and renal vessels. So there's much more than just simple increasing afterload and preload from angiotensin mechanism. So this plays a part in cardiorenal syndromes. And over a long period of time, when patients have chronic renal failure and this persists, we do have chronic sympathetic stimulation happening from all this. And that has been shown consistently to subsequently cause decreased sympathetic receptor density in the heart, a rationale for why we use beta blockers in heart failure. There is receptor uncoupling from intracellular signaling. The receptors are completely uncoupled, that they are not effective anymore when they are stimulated. Somehow this creates an environment where there is a lot of left ventricular hypertrophy, increases apoptosis of the cardiac myocytes, and there is increased secretion of neuropeptide Y, which is implicated largely in increased atherosclerosis, again happening over a period of time. And if a patient has decreased renal dysfunction, the catecholamines hang around in the blood for a much longer time, exaggerating all these efforts and maybe perpetuating this kind of pathway that progressively worsens the other organ also. People have also looked specifically at the renal sympathetic stimulation. Not only the global sympathetic activity is important, what has happened at the kidney levels from renin-angiotensin and renal sympathetic activity somehow has a systemic effect, very clearly shown by the study where they went and did selective denervation of the renal nerves, decreasing the sympathetic activity at that level, and over a period of a year, they showed that substantial reductions in systolic and diastolic blood pressures occurred. So somehow renal sympathetic activity has an overall atherosclerotic effect from all these mechanisms, and trying to take it separately off seems to be helping in patients with hypertension. Whether this can be used as a therapeutic modality is experimental, of course, right now, and people are looking into it much more carefully. Next link comes to erythropoietin. Anemia has been shown to be an independent adverse prognostic factor in heart failure patients. Independent of the EF, independent of the renal dysfunction, anemia is a worse prognostic factor. And we all know erythropoietin is decreased in renal failure and is elevated in heart failure. The only unifying hypothesis is that erythropoietin somehow is necessary. When it's not being produced, then probably we lead more cardiac myocyte apoptosis, and probably in patients with heart failure where there is increased erythropoietin, maybe there is decreased sensitivity to these erythropoietin, which both prevents cardiac myocyte apoptosis and also acts as a growth factor, and both this contributing to worsening dysfunctions of the respective organs. People have tried to use erythropoietin replacement in chronic renal failure for various reasons where it's been shown to improve outcomes dramatically. Such studies in large scale are not available in heart failure patients yet, but this is one other avenue where research is ongoing right now. So moving from pathophysiological reasons of why heart and kidney are linked to looking at the common biomarkers which we are probably using and see if there is any crosstalk there. This one slide nicely depicts that as the renal function gets, as the heart and end-diastolic wall stress on the right side gets worse, your BNP levels keep going up. That is very well known. Patients who have more and more stretch of the atria, they produce more natriuretic peptides. But this effect is amplified when the kidney functions are also respectively worsening. Whether it is related to decreased clearance of the BNP or is there secondary increased production of the BNP is kind of unclear at the present time, and whether the production is purely because of atrial stretch or is it because of the vascular trauma that happens in these patients. Is it because of atherosclerosis? Is it because of cachexia? It is very unclear at the present time, but clearly BNP levels are very elevated in patients with heart failure, with renal failure, and the effect is amplified when the patients have both. And people have argued that the cutoff limits of BNP have to be raised so if an ESRD patient has a high troponin level, they have a higher risk of cardiovascular death compared to patients with a lower troponin levels, even if they are asymptomatic. Probably they think the troponin comes from non-ischemic cardiomyopathy, microvascular injury, again worsening left ventricular hypertrophy. Excuse me. Cystatin C, which is a new biomarker that is being used regularly to screen for acute kidney injury, correlates with mortality in heart failure patients. In fact, there is a series of studies where patients have looked at serial cystatin levels in healthy individuals, and that seems to predict risk of cardiovascular death in normal, healthy, otherwise healthy individuals. And when added to pro-BNP, seems to increase the prognostic value, and the ROC curve seems to look better when cystatin C is added to pro-BNP in patients with heart failure. So clearly, the biomarkers of one disease which we traditionally use somehow implicate the prognosis of the other disease and seem to be useful in stratifying patients' outcome based on these levels. Looking at the epidemiology of renal failure and heart failure, most studies say there is a prevalence of around 30 to 40% of patients who have moderate to severe impairment in their heart function. And more importantly, patients' renal functions get worse when the heart failure is being treated and probably leads to inappropriate or inadequate treatment of the heart failure. I will come to it in my last slide. Again, probably causing worsening mortality in these patients. And as I showed you in the first slide, the baseline renal function sometimes precedes over even IHEART class or functional class of patients in heart failure and predicts their mortality significantly in an overall lot of studies. Looking at cardiovascular mortality in patients with renal impairment, in one study, patients died more of a cardiovascular death than a renal death if they have end-stage renal disease, purely from atherosclerosis, arrhythmias, and long-term changes in the ventricle size and hypertrophy, probably also related to suboptimal treatment of most of these issues, which would otherwise not be an issue. And the risk of cardiac death is amplified 10 to 20 times than in general population. And interestingly, in one study of about 100 patients, when they transplanted the kidney, the EF improved from about 30% to 50%, and 70% of the patients who got transplanted improved their ejection fraction completely. So again, clearly, one organ leads to the dysfunction of the other organ. therapeutic implications, I would argue that probably this effect of heart and kidney interaction is probably amplified when we try to manage these patients, and probably contributing to the added mortality and morbidity which cannot be delineated from a pathophysiological point of view versus an iatrogenic point of view. Increased creatinine could be perceived as overdiuresis in a patient with heart failure, and probably suboptimal diuretic therapy could be given. Reluctance in initiation of ACE inhibitor when the creatinine is marginally elevated. There is no consensus to say beyond which creatinine level ACE inhibitor should be withheld at the current time, and patients may get suboptimal treatment. ACE inhibitors improve survival, and withholding such therapy may actually add to the mortality of these patients. If patient has quote-unquote heart failure and renal failure on paper, inadequate fluid resuscitation, I just use sepsis, but it could be for anything. Intraoperatively, trauma patients, burns, anything could amplify the effect of these two diseases on outcome. We may initiate renal replacement therapy much more faster than if a patient who has normal kidney function, because we know there may be diuretic resistance. And diuretic resistance itself has been shown to have a poor prognostic factor in patients with heart failure. And when we do initiate renal replacement therapy, we would have a tendency to prolong using it, because we are worried that once we stop it, fluid removal becomes an issue, and that could add to the mortality. And all the complications related to renal replacement therapy, including hemodynamic instability, line-related sepsis, and all that, also probably add to the mortality of these patients. And finally, we clearly know that the interventions to remove fluid overload may cause decreased renal perfusion. The classic example is the nisiritide. When it came out, it was supposed to be a beautiful drug, causing vasodilatation, at the same time natriuresis. So for a failing heart, it was decreasing its afterload, decreasing its preload, and causing diuresis. But over time, we found that the incidence of acute kidney injury is significantly escalated, that AHA has clearly recommended not to use nisiritide in patients with heart failure with renal dysfunction for this reason. Inotropes, unfortunately, do not improve renal and overall outcome in patients with heart failure. A large study looking at milrinone infusions in patients with acute exacerbations of chronic heart failure clearly showed that using milrinone does not alter outcome in these patients. But these are not the sick ICU patients that we would see routinely, were generally excluded from the study. Phenoldotam, another drug that's supposed to protect the kidney by renal vasodilatation and causing a gentle diuresis, causing hypotension, again, afterload reduction, diuresis, and increasing renal blood flow, theoretically would have made sense, for whatever reason does not work and worsens the outcome in certain patients purely because of the hemodynamic instability it causes. So again, clearly giving the message that going after one particular pathway seems probably not to help, and we need to look at alternate reasons of why one organ fails when the other, and try to target those things. Quickly summarizing what I told you, if you have a patient who's got a progressive cardiac dysfunction, there is increased sympathetic activity, increase in renin-angiotensin-aldosterone axis, increased activation that causes both increased preload and afterload, more oxidative stress, and more atherosclerosis. And same way, kidney also comes back and does most of this back to the heart, causing worsening left ventricular hypertrophy, cardiac myocyte apoptosis, and worsening of the function of the heart also. So to conclude, I would like to say that there is a complex crosstalk exists between the heart and the kidney, for sure. Dysfunction of one organ has been shown consistently to be associated with the dysfunction of the other. Pathophysiologically, there are numerous links that link one organ to the other. Epidemiologically, these pathophysiological links seem to be valid. These have been again corroborated by biomarkers of one disease able to predict the prognosis of the prognosis of the other organ, and when combined seem to have a better prognostic value. This interaction and understanding of this interaction has several important therapeutic implications that we need to keep in mind when treating such patients. And although definite relationship exists between one disease and the other, is it causative versus just an association, is very unclear right now, and probably we need more data to say how much of this is causative versus just a mere association that could be an epiphenomenon happening systemically throughout the body. Thank you.